All right, good morning. I want to get started. So I'm going to go through, this first session is carotid artery disease, cerebral vascular disease. So I will go through the questions and I will discuss with them one at a time. And I would like, as I finish the questions, you can use the chat function to type in your answers, and we'll go over them. All right, here we go. During a routine carotid endarterectomy operation, the mandible is retracted to gain distal exposure. This maneuver can lead to which of the following problem? Number one, A, ipsilateral drooling, B, ipsilateral tongue deviation, C, contralateral tongue deviation, D, anterior two-third tongue palsy, or E, hoarseness. All right, so for the attendees, go ahead and type in your answer if you can. Michael, are you there? I don't see any response.
Yes, I'm here. One of the candidates typed in A.
Okay, I don't see.
Someone else said B.
Let me see if I can find out.
Are you seeing the chat come up?
All right. All right, so, okay, so I encourage folks to type in the answers. This is as interactive as I want to be.
Dr. Lin, do you see the chat come up on your screen?
Yes, I do. I see two answers. One person respond A, one person respond B.
Okay, good. I just want to make sure you can see. Okay, all set.
Got it. All right. Okay. Okay, fine. The answer to this question is A, ipsilateral drooling. The reason why that's happening is because this particular maneuver, the marginal mandibular nerve of the facial nerve is retracted. The nerve is injured. So when you retract the nerve using the Army Navy to pull up the mandible, this nerve can lead to ipsilateral drooling due to the injury of the particular facial nerve, or the marginal mandibular branch of the facial nerve. Our next question. Which of the following maneuver can be used to gain distal exposure of the internal carotid artery during a carotid artery operation? A, division of the anterior belly of the digastric muscle. B, anterior subluxation of the mandible. C, posterior subluxation of the mandible. D, division of the ansa cervicalis nerve. E, transverse mandibulotomy. All right, folks, go ahead, tell me your thoughts. Give you a few minutes. Okay, I have, okay, somebody put down C. I had a person put down A. The response from folks are C and A. All right, the answer is anterior subluxation of the mandible. This is a fairly common question. Shows up on the board exam. Let's go over that real quick. So this slide's outlining some of the maneuvers can be used to gain distal exposure. So this is a scenario where you do your carotid surgery and you discover the bifurcation is very high, very distal. And so there are a set of maneuvers you can do. So the standard carotid incision, which you make incision along the anterior border of the sternocleidomastoid muscles, will get you somewhere about the upper half or upper third of the C2, the second cervical vertebrae area for exposure. If that's not enough, the next set of maneuver you can do is to divide the posterior belly of the digastric muscles. By taking down that particular muscle, you will get about upper third of the C1, the first cervical vertebrae. And if that is still not enough, then one can consider is in an elective setting, do anterior subluxation of the mandible. Now, I say elective setting because to do that, you have to perform nasotracheal intubation. So in a setting of emergency, this may not be an option if a patient has an oral tracheal intubation. But if you know ahead of time, anticipating a distal exposure might be a challenge, you can do a subluxation of anterior portion of the mandible. Now, the next step you can do is styloidectomy. That will get you an upper portion of C1. And the last maneuver will be lateral mandibulotomy. Now, many of these procedures you may not have seen, but I can assure you they have shown up on your exam. So here is anatomically what these maneuver means. So this is the area of the TMJ joint. So when you lower your jaw, when you eat, your ramus of the mandible or the mandibular condyle is sitting inside the glenoid fossa. Here's your air canal, external auditory canal. So when you chew, your coronary process is lower, and this mandibular condyle is actus fulcrum, sitting inside glenoid fossa. So in the standard carotid surgery, we make incision along the anterior border of the sternocleidomastoid muscles. You get a triangular exposure. Now, if you knew ahead of time that this exposure is not going to be adequate, you can do an anterior subluxation that convert this exposure from a rectangular exposure to a more from a triangular exposure to a rectangular exposure. That will get you exposure all the way to the lower part of the styloid process. Again, that requires a nasotracheal intubation, usually done in an elective plant setting. Now, if that is still not enough, you can take down the styloid process. Again, that's a maneuver which I have mentioned here, styloidectomy, taking down this particular bony landmark. That will get you upper C1. And if that is still a problem, then you can do a lateral mandibulotomy, take an osteotome, divide it in half, flip it up, and get your exposure all the way to the entire portion of the C1. And later on, once the operation is done, you have an oral surgeon come in and flip back down and put a plate to secure to reconstruct the mandible. So unlike the anterior subluxation, if you do that, you have to wire the jaw shut with wires to secure the TMJ joint for probably 2 to 3 months. But in the setting of lateral mandibulotomy, you do not have to wire your jaw closely for 2 to 3 months. So that's the maneuver required to gain distal exposure of your carotid surgery. Alrighty, next question. And in this picture depicts some of the muscles. So when again, this first muscle is the sternocleidomastoid muscles. It goes down laterally, so you make incision along this first muscles. And if that is a problem, the next maneuver is dividing the posterior belly of the digastric muscle shown here with my mouse. So that muscle is divided next. And then moving down here, you can divide the styloid process shown in this picture. That's a styloid process that drapes over this styloid hyoid muscle. So you can take that down. So these are maneuvers depicted in this picture to show that in a stepwise sequence, what muscles can be divided to gain distal exposure. This picture is just to show that the external branch of superior laryngeal nerve travels closely to the external branch of the laryngeal nerve travel closely to the parathyroid artery. So that when you do your surgery, I usually put a vessel loop around it. I don't divide this artery because the risk of injuring the nerve is quite high. So that just pictures reminds you that this nerve travels closely. You want to preserve that nerve. All right, next question. What is the most commonly injured nerve during a carotid endarterectomy operation? A, hypoglossal nerve, B, superior laryngeal nerve, C, glossopharyngeal nerve, D, recurrent laryngeal nerve, E, vagus nerve. All right, folks, tell me what you think. All right, I have some people respond to E. Some people respond to C. All right, the answer is E, vagus nerve. No, I'll go on. I'll come back and talk about these questions in a second. During a carotid endarterectomy operation, the patient developed bradycardia and hypotension during carotid artery dissection. This is due to the stimulation of which the following nerve branch: A, vagus nerve, B, glossopharyngeal nerve, C, hypoglossal nerve, D, facial nerve, E, recurrent laryngeal nerve. All right. Do I have any? Okay, I have some folks put down A, vagus nerve. All right, this is a fairly common problem that can occur during this operation, and it's also a fairly common scenario that can show up on your exam. So question asks, during your surgery, are you dissecting around the carotid artery, carotid bulb? Patient become bradycardic. That is because of irritation of cranial nerve number 9, glossopharyngeal nerve. So this nerve usually drapes off around the area of the carotid bulb. So when you dissect around this area, patient could become bradycardic and hypotension. This is the same nerve that can also occur when you do carotid artery stenting. When you inflate a balloon, the glossopharyngeal nerve can be irritated, resulting in similar hemodynamic problem, bradycardic and hypotension. And so that's nerve is being irritated. Now, next question. Carotid sinus nerve is a branch of what? A, vagus, B, hypoglossal nerve, C, glossopharyngeal nerve, C, spinal accessory nerve, and E, trigeminal nerve. Okay, I have response from folks that are glossopharyngeal nerve. Okay, the answer is glossopharyngeal nerve. So, right, this picture basically depicts that this nerve, glossopharyngeal nerve, just usually it's very difficult to see. And obviously during the carotid artery dissection, you need to be aware when you dissect along with your medicine bomb around this area, you can irritate these nerves. It's very hard to see with your naked eyes. And so if you do that operation, particularly during this maneuver, dissecting out the carotid bulb, separating the internal and external carotid artery, you want to make sure the anesthesiologist is aware, and perhaps you can turn up the volume of your EKG rhythm. You can hear the heartbeat. So should you encounter bradycardic, you can take lidocaine and gently infuse some lidocaine along the adventitial plane, and that will resolve the issue of bradycardia. The heart rate can return to normal, or you can have the anesthesiologist give some atropine to reverse the bradycardic problem. Alrighty, next question. 62-year-old female undergoing carotid endarterectomy surgery for asymptomatic